So it's nice to be here again, and thank you for the generous introduction. And as you said earlier, so we have a very short segment planned for today, which is basically we're just trying to understand the basics of a very important and common topic, and which is a part of everyday conversation as far as patients and the medical community is concerned. So it's about the basic facts of cholesterol and its myths and facts. So over the next couple of minutes, what I would like to do is not to get too technical regarding this, and I would just like to approach it from a common conversation point of perspective. And of course, we can dive into the technicalities in the Q&A session if necessary. But there are some key clinical points which I'd like to drive across in the next couple of minutes. So we all know that cardiovascular, why are we discussing this today? And it's because cardiovascular disease is tremendous. It's growing exponentially. And in fact, it's the leading cause of death worldwide. And it leads to close to 18 million deaths per year globally. And that's a conservative estimate. And it's one of the top leading causes of premature death globally. So if you look at the other diseases in terms of percentages, one chronic disease that can be comparable is cancer. And the cardiovascular disease contributes almost close to 37% of that global burden. So the problem is huge, and the magnitude of the problem is quite extensive. And as a result of the problem, it's important to understand what contributes to the problem. So if I can just get my point, yeah. So you can see multiple risk factors, which in fact contribute to the problem of cardiovascular risk, sometimes alone, sometimes in combination. And some of these risk factors are very commonly known to all of us. And of course, the problem that we're discussing today is related to lipid disorders, where you have a cholesterol elevation, which contributes to increased cardiovascular risk. And of course, by cholesterol, it could be LDL cholesterol, which is popularly known as the bad cholesterol, HDL, which is also popularly known as the good cholesterol, and a lower level means an increased cardiovascular risk in general terms. And triglycerides is another a cholesterol entity, which again increases the cardiovascular risk. So apart from these major cardiovascular risk factors, lipid disorders is a predominant risk factor for cardiovascular risk. And that's something which we're going to talk about in the sense, some of the myths associated with cholesterol and some of the facts which act as a counterpoint to those myths. So what are the format which I thought I will follow today will be a myth versus fact kind of format. And one of the commonest myths that we often find from the patient population is that you don't need your cholesterol checked until you reach middle age. So this was a predominant form of thought process up until a few decades ago, that probably when you touch your third decade or fourth decade is the time when you really want to sort of look at your cholesterol levels. But the fact is quite different, because now if you look at the guidelines, see, the process of cholesterol deposition in your blood vessels can begin as early as 10 years of age, and sometimes quite even earlier if there is a strong family history of heart disease. So that it doesn't mean that you need to keep checking it right from 10 years of age or 15 years of age, but on a general aspect, the current cardiovascular guidelines, if you look at the American Heart Association or the European Society of Cardiology guidelines, the recommendation is to please get your cholesterol and other risk factors, but particularly cholesterol checked at 20 years of age, and at least every 4 to 6 years after that, if it's relatively normal. If it's quite high and you have been started on medications or lifestyle modifications because of your high cholesterol, probably you need to bring down that interval less than 4 to 6 years. But if you have a very high cholesterol at age 20 and you have been advised some form of therapeutic measure, then I think the interval would be lower than 4 to 6 years. But if it's normal, it would have to be something like every 4 to 6 years after 20 years of age. So this is the myth. So this myth is not true. So at 20 years of age, at least once, you must get it checked. And then based on that, you can decide on the interval, whether it's every 4 to 6 years or less than that, depending on the level. The second myth we often find in social media, public conversation, is that only overweight and obese people have high cholesterol. Well, it's not entirely a myth. There is some truth to this myth. The fact is that, yes, overweight and obese people are more likely to have the increased chances of having high cholesterol. We have seen patient populations who are overweight and obese who do have a normal, at least in the true lab sense, a normal level of cholesterol. But again, it's a cardiovascular risk factor. That is, overweight and obesity is a cardiovascular risk factor. So the counterpoint to this myth would be that there is a grain of truth in this. Overweight and obese people are more likely to have high cholesterol, but being thin really doesn't protect you from the problem. And in our patient population that we have seen over so many years, we can demonstrate clearly patients who have a normal BMI, a normal weight, and sometimes even a BMI which is lower than normal, who have very high levels of cholesterol. So the weight as an index to point towards the likelihood of cholesterol is fairly accurate in a large proportion of patients. But we do have a large number of patients who have a normal weight and high cholesterol. So regardless of your weight, diet, and level of physical activity, you should have your cholesterol checked on a regular basis. And that's going back to the first myth that we saw, that once you cross 20 years of age, at least, I think the rational step is to check it at least once and then decide on the interval after that. So it's not only the obese and the overweight people who have a cholesterol problem. The other subset of the population who may not fall in the overweight or obese classification, they can also have a cholesterol issue. The other myth was gender. So for quite a long time, and if you look back, if you dial back the clock to 2 or 3 decades ago, having a high cholesterol was considered to be a gender bias was perceived in terms of the problems a high cholesterol could give the cardiovascular system. So that's not true anymore. But there are some points that we should understand about the gender and cholesterol relationship. Now, it's true that once people age, as the aging process proceeds, or once people gain weight, regardless of gender, the cholesterol levels tends to rise, and that's a fact. Now, when it comes to gender, when it comes to women, it is also true that premenopausal women, they tend to have higher levels of a hormone called estrogen, and which acts as a positive factor in the sense that it raises the level of good cholesterol. So when you have premenopausal women with high estrogen levels, your HDL cholesterols are on the higher side, and hence it's considered to be, to some extent, protective. Now, interestingly, as women pass the menopausal stage and they cross over into the postmenopausal stage, they tend to have a higher level of LDL cholesterol because the protective effect of estrogen tends to wane off. So in this myth, there is not much of a grain of truth. It's not only a man's problem. And the relative protection that a woman has in the premenopausal stage because of the high estrogen tends to wane off as the woman closes or crosses over into the postmenopausal phase. So I think it's quite clear that the process of aging, the process of weight gain, uniformly contributes to a very high likelihood of increased cholesterol. In premenopausal women, there is some protection by high estrogen, and in the postmenopausal phase, the protective effect wanes off to some extent, and the LDL cholesterol, which is popularly known as the bad cholesterol, has a tendency to rise. And so this trend in this progression of a woman's cardiovascular protective effect as a result of estrogen is quite interesting in this way. So there's another myth, is that if you haven't checked your cholesterol, if your healthcare provider hasn't mentioned your cholesterol levels, you're pretty okay. That's not true. So I think the counterpoint to this myth is that it's simply not true. And we saw it from the very first slide. And And if you look at the recent slogans of the World Heart Day celebrations in September every year, there is an increasing trend of advocating personal responsibility for health. And once you've turned 20, I think every person must request the healthcare provider to have a basic assessment of your risks for cardiovascular disease, and that includes checking your cholesterol once. And of course, to determine where, and including your cholesterol level in a risk scoring system, which is very commonly available. Even a layperson can do it online by just inputting the levels of your cholesterol, levels of your blood pressure, and other risk factors. And you can assess your 5, 10-year, 15-year cardiovascular risk. And essentially, you're estimating the risk for cardiovascular disease or a stroke. So if you're between 40 and 79 years of age, and in which case the assessment of these scores have great value, you can request your healthcare provider to use these blood test reports and probably guide you regarding what is your 5, 10, or 15-year cardiovascular risk and what measures can be undertaken to mitigate that risk. So this is a very popular myth. So your cholesterol level is a result of your diet and physical activity level. So it's not as much as a myth as a half-truth. So definitely, the diet and physical activity levels definitely affect your cholesterol. There is no question about it. I think there's been a lot of talk in social media, the fact that the diet level, the cholesterol in the diet really doesn't matter, and things like that. But I think we're all responsible scientists here, and as part of that responsibility, the responsibility also includes educating the public regarding the real scientific facts. And the fact remains, the diet and physical activity level really contributes significantly to the cholesterol. But the important point to understand is they're not the only factors. For example, in our clinic, sometimes we see patients who have a very healthy lifestyle. They exercise quite regularly. They are not on medications, but they exercise quite regularly. They really watch their diet, but they have, for example, an LDL cholesterol, which is 170, 180, and sometimes more than 200, which is an exceptionally high level. So what's going on here? So you have patients who really taking care of themselves in every way that they possibly can, but every time the lab turns out results which are quite high. The cholesterol levels are quite high. So this is where you must understand that there is an element of familial hypercholesterolemia. In simple terms, there is a genetic predisposition in certain families to have a very high cholesterol level, irrespective of the diet control or physical activity level. Now, having said that, it doesn't mean that the diet control and physical activity level do not mean anything in these patients for cholesterol control. They are very important. But the point to understand is, in these patients, in these families, the diet and the physical activity level alone may not be enough to control the cholesterol levels, because the whole process is being driven by a genetic predisposition. And we call it familial hypercholesterolemia, in which case it's very important to understand the family history of heart disease, whether there has been history of heart disease in the family at young ages. And these are points in the clinical history which are very significant to cardiovascular physicians. And based on the family history, the necessary risk modification measures must be advised. And almost always, with patients with a familial hypercholesterolemia with very high cholesterol levels, are often advised in almost all cases medication strategies to bring down their cholesterol levels. So this is an example from the Harvard T.H. Chan School of Public Health, one of the premier public health schools in the world. And this is an example, since we were just mentioning the points about the diet and cholesterol. So this is a healthy eating plate. And this is, in my opinion, this is a very easy infographic to remember. So you just divide your plate into these quarters, and you have the green quarter, which represents vegetables. And there's a proportional representation here. It's not just the colors of the quarters which are important. If you look at the proportions which the quarters represent, in fact, it's not true quarters. If you look at the proportions of the segments on the plate, which is represented here, the adequate weightage is applied there. So if you look at the vegetables have a predominant position, fruits as well, whole grains, definitely, and of course, healthy protein, which is low on fat. And on the left-hand side, you can see healthy oils have been clearly marked, and of course, a healthy quantity of fluid intake per day. So this is a useful infographic to quickly understand what should be the general architecture of a healthy eating plate. And of course, staying active is as important as a healthy eating plate. So we come to another conversational myth, is that once patients are diagnosed with having high cholesterol levels, and they might be overweight, or they might have an unhealthy lifestyle. So they usually prescribe cholesterol medications. So the myth is taking cholesterol medicines, you don't need to make diet and lifestyle changes. Why not let the medicines take care of everything, and why not continue with a sedentary lifestyle? Why do I need to have a regular physical activity? This is a myth, because the counterpoint to that is, as important as taking cholesterol medicines are in reducing your cardiovascular risk, it's also equally important to reduce your risk for heart disease and stroke with maintaining a regular physical activity and definitely making positive changes into your diet, as we just saw in the previous slides. And of course, the kind of physical activity which is usually recommended by the cardiovascular societies is 30 to 45 minutes of physical activity, at least 4 to 5 days in a week. And this is considered to be a reasonable level of physical activity. So the benefits of having a healthy lifestyle in terms of a healthy physical exercise routine and positive dietary changes have incremental effects to the medicines that you're taking. So the medications are not taking over the role of a healthy physical exercise routine or a positive diet or dietary modification. They can take care of the increased levels of cholesterol in the blood, but these lifestyle changes have an incremental effect in addition to the medication. So it's quite important to have both of them on board. So otherwise, we are left with the dangerous combination of portable technology, inactivity, consumerism, obesity, and finally contributing to lifestyle diseases. So it's not just the medications which are supposed to help the population lower the cardiovascular risk. There has to be real motivation from the patient to incorporate healthy lifestyle changes into their routine. So this is an interesting myth. This is a quite subtle myth, but it's important. It's quite important at the same time. So, of course, we now know that nutrition labels are quite universal now for the food product that you're buying off the shelves. So if the nutrition label shows no cholesterol, the food is heart healthy. Sometimes you can see stickers with which jump at you off the shelves saying it's 0 cholesterol, no cholesterol. The food is heart healthy. This is not true. And I'll tell you why it's not true. See, when they say it's 0 cholesterol, it does not mean it is 0 fat. It just means that the cholesterol level in terms of LDL cholesterol, or let's say other types of cholesterol. So it's not being specified here. So 0 cholesterol often means, it doesn't mean that the percentage of fat is less. So even these food articles which are being marketed as no cholesterol are sometimes high in bad fats. So the bad fats are essentially saturated fats and trans fats that you see in deep fried products, or sometimes you see in processed food. So it's very important to check the food label, not for the quite attractive no cholesterol sign. I think the thing that we should be looking at is saturated fat, trans fat, and of course, total calories. So it's not only the presence of the saturated fat, trans fat, and total calories, we also should be aware of the fact that the serving size may be based on smaller than the entire package. So there are numerous ways in which numbers can be manipulated to give a false sense of security. So labels such as zero cholesterol, I think, should be treated with some suspicion. And I think if one is inclined to look at the nutrition label, I think one should look for the right parameters such as saturated fat, trans fats, and total calories, and of course the serving size. So one of the other myths, and I think this is very important because we are having an explosion of childhood obesity, not only in the developing countries, but as well as the developed nations. So this is something that we need to really worry about, because as I mentioned, the process of cholesterol deposition and the disease process per se in the blood, in the walls of the blood vessels, start as early as 10 years of age, in certain instances, earlier than that. So the popular myth is that children don't need to worry about cholesterol. Things will take care of themselves. That's a myth. And close attention must be paid to certain facts which can act as a counterpoint to this myth. Children can have high cholesterol levels. It's not as if children don't need to worry about cholesterol. Just like adults, they can have very high cholesterol levels, but they may not have the impact of high cholesterol levels at that point in time. Why? Because their blood vessel system, their vascular system is quite young and adaptive. So even if their cholesterol levels are high, even if the deposition is taking place, by virtue of the fact that they have age on their side, their vascular age, the age of their blood vessels are young, and they may not have the impact of the damaging process of cholesterol deposition as you would have in, let's say, a 60-year-old man or a 70-year-old individual. But the point is this: they are exposed to cholesterol. The child who has high cholesterol has been exposed to a high level of cholesterol for many, many years once the same child reaches the age of 60 or 70 years of age. So the point I'm trying to drive at is that the total burden, the cholesterol burden, the years for which this child has had a cholesterol burden is quite high. And this translates into a very high likelihood of cardiac disease when this child grows up to, let's say, the 4th decade or 5th decade and above. So the consequence of the high cholesterol in children will come back to haunt them when they grow up. And if the child has a healthy modification of their lifestyles in between, it's definitely helpful. In the absence of such healthy lifestyle modifications, it's definitely going to be a problem as the child grows up. So children can have high cholesterol levels due to a number of reasons. One, it could be a genetic problem, as I mentioned earlier. This particular child could belong to a family where there's a genetic predisposition to have high blood cholesterol levels. As I mentioned, the term is called familial hypercholesterolemia. If this is the case, then children, when they grow up, as early as 20 years or 30 years of age, they can have issues such as strokes or heart attacks, because familial hypercholesterolemia is an entity which leads to a very high incidence of heart disease in the 2nd or 3rd decade of life. Children can also have high cholesterol due to of course bad lifestyle choices, and of course with the influx of a lot of fast food, sedentary lifestyle, childhood obesity. These are correctable factors. Unlike familial hypercholesterolemia, unlike genetic predisposition, these lifestyle measures can be corrected. So it's either genetically determined in children, or they can have a high cholesterol because of bad lifestyle choices. And I think as parents, all of us have a definite responsibility in paying attention to the cardiovascular health of our children quite early on in their life. So I'll end my talk with one last segment, and this is about LDL cholesterol. And I'm going to get a little bit, so far, if I have not gotten a bit technical, I'd like to get a little bit technical over the last two slides, because it's very important to understand the scientific evidence here. And the reason why I added these last two slides as a part of this segment is that if one has been paying attention to social media, let's say Facebook, Twitter, Instagram, and of course popular science segments in newspapers, and often you find that there are numerous opinion pieces on many people coming out with their opinion regarding LDL cholesterol, and saying that LDL cholesterol is not important. LDL cholesterol really doesn't need to be taken into account. It doesn't really contribute to heart disease. And you have plenty of people on YouTube channels advocating the same opinion. And as a result, general public is a little confused. And as cardiovascular physicians, we often have people come back to us, people who would like to understand this process better, because on one side, there is a lot of feedback from the medical community that LDL cholesterol is harmful. It is the bad cholesterol which leads to heart disease and stroke. And on the other hand, you have a large body of popular opinion pieces in social media which says otherwise. So as I mentioned before, as clinical scientists, I think it's our responsibility to look at the scientific proof, and it's also our responsibility to communicate this scientific proof to the public, and so that they can make their informed opinion about where the facts lie. So this is a very busy slide, but there are only few things which I need you to understand about this. So essentially, on the x-axis, so this is the magnitude of exposure to LDL cholesterol. So it tells us how long a patient is exposed to LDL cholesterol in terms of course, in terms of a time period. On the y-axis, we have the proportional reduction in the risk of heart disease. So how much of percentage of risk reduction has been achieved in the risk of heart disease? And all the small squares that you're seeing are all the scientific studies which have been conducted to look at this. All right, so this is what it is. So on the x-axis, you have the magnitude of exposure to LDL cholesterol in terms of the LDL cholesterol levels. And on the y-axis, you have the degree of reduction in the risk of heart disease. All right, so we have to understand how important is LDL in three categories. One is called Mendelian randomization study. So what does that really mean? So it essentially looking at two groups of populations. So it's looking at population group number one, which has a genetically low level of cholesterol. So there are families with genetically high levels of cholesterol, and there are families with genetically low levels of cholesterol. So if you take a group of families with genetically low levels of cholesterol and a group with genetically high levels of cholesterol, you can clearly see, and you follow them over many, many years, you can clearly see that the patients with, or the families with genetically lower LDL cholesterol are the ones that definitely do better. They achieve a higher and higher and higher incidence, higher chances of reduction in the risk of coronary artery disease. So that's level of evidence number one. Now let's look at another layer of evidence. These are called prospective cohort studies. So what does this term really mean? So essentially you are taking two groups again. On one group, you are taking large hundreds and thousands of patients with low LDL cholesterol. And on the other hand, you're taking a group with high LDL cholesterol. It's not genetic here, like Mendelian, so it could be due to many reasons. And you're following them over decades. And you can clearly see, as a result of all these small squares, of all these small studies, you can see that these patients, the higher the level of the cholesterol levels, the lower their degree of cardiovascular protection. And it's quite clear. Let's look at the final layer of evidence, randomized controlled trials. So what do they mean? So essentially here, we are splitting populations into two groups. In one group, we are taking patients with a high LDL cholesterol, and we are treating them with medications to lower their cholesterol.
And in the other group, we are taking a population with high LDL cholesterol, and we are not giving them, or let's say we are only giving lifestyle modifications. We are not giving them the specific medications. Numerous small squares, numerous small studies have addressed this question, and there is clear evidence to say that the higher your cholesterol levels in such studies, the lower is your cardiovascular protection. So on these three levels of evidence, we are on firm ground to finally say that LDL cholesterol really does matter scientifically, and in the truest scientific sense, to protect the patient and their family from the cardiovascular risk. It is absolutely essential to bring LDL cholesterol down to reasonable levels depending on the risk level. So essentially, this is a summary of all the cardiovascular trials which have looked at this question, and we have now concluded. We began with lower is better in terms of LDL cholesterol. Now in 2016, we have reached even lower is even better, and in 2020, we are now saying lower is best. And if you look at the panel down, you can see that every reduction of LDL cholesterol of 39 milligrams per deciliter. So you bring LDL cholesterol by a quantum of 39, leads to a 22% reduction in cardiovascular events like a heart attack. Now these are excellent numbers, whichever way you look at it, whichever way that you want to analyze it. So I'll conclude by saying that LDL cholesterol really matters for cardiovascular protection and a stroke. And of course, these are some, I'm not going into details over here. So these are some of the risk categories that we consider when we want to initiate patients on cholesterol therapy. And as you can see, there are various levels of risk. And based on that, our targets will differ. So the real change is that of late, patients with a very high risk category need their LDL cholesterols to be less than 50 milligrams per deciliter. And of course, in the other high risk categories, we are aiming for something like less than 100. But the general theme is that lower is better. So I will end with this slide.